Welcome back, deep divers. Today, we're diving deep into the world of antiplatelet drugs.
Ooh, sounds intense.
It is, actually. You guys sent in some really great sources on this topic.
Always love that. It keeps us on our toes.
Seriously. And we even have some insights from a presentation by Dr. Khaled Hasan.
Professor of clinical pharmacology. I've heard him speak. He's brilliant.
Exactly. So we're definitely starting this deep dive with an expert perspective.
Awesome. Can't wait.
So, antiplatelet drugs, right? They're all about preventing blood clots. But the science can get a bit, well, complicated.
Yeah, it's a lot of moving parts for sure.
Ready to try and break it down together, make it, understandable.
Absolutely. I think it helps to think of it like a puzzle.
Ooh, I like that.
Yeah, to understand how these drugs work, we need to first understand how our bodies form clots in the first place.
Right, because it's not like clotting is always a bad thing, right?
Exactly. In fact, it's crucial for, basic survival.
Like not bleeding out if you get a cut.
Exactly. It's really a remarkable process when you think about it.
So how does it work? What's going on at the microscopic level?
Well, think of your platelets, those tiny cells in your blood, like little construction workers.
Okay, I'm visualizing tiny hard hats.
Perfect. So when there's damage to a blood vessel, imagine a distress signal goes out.
Like a little siren wailing.
Exactly. And those platelets, they rush to the scene, all ready to work.
To patch things up.
Exactly. They stick to the damaged area, they stick to each other, they form a plug, a clot to stop the bleeding.
So it's like a well-coordinated emergency response team. Incredible how our bodies just do that automatically.
It is, isn't it? But sometimes those construction workers get a little overzealous.
Ooh, I see where you're going with this.
Yeah, they start building clots where they're not needed.
And that's where things can go wrong.
Precisely. Those unwanted clots can block blood flow in important places, your heart, your brain.
Leading to serious problems like heart attacks or strokes.
Exactly. That's where antiplatelet drugs come in. They're like the traffic cops.
Ooh, I like that analogy.
Making sure those platelets, those construction workers, only go where they're supposed to.
Keeping those roads clear. So let's talk about the most well-known traffic cop on the block, aspirin.
Ah, good old aspirin. It's been around forever.
It really has. But how does it actually work? What's its secret?
Well, aspirin targets a specific enzyme called KEOX1.
KEOX1. I remember seeing that in my research. What does it do again?
It plays a key role in making a chemical messenger that tells platelets to activate to become sticky.
So it's like sending out the go signal to those construction workers.
Exactly. Aspirin basically blocks that signal.
Wow, so it's like cutting off communication. No more go signal means no more unwanted clots.
Exactly. And what's really interesting about aspirin is that it does this irreversibly.
Irreversibly? What does that mean?
It means it's a one-time hit. Aspirin permanently disables those KEOX1 enzymes.
So even after the aspirin itself is gone from your system?
Those platelets remain less sticky for their entire lifespan.
Wow, that's amazing. So a single dose of aspirin has this long-lasting effect on those platelets.
Exactly. It's pretty powerful for such a seemingly simple drug.
No wonder it's so widely used, right?
Absolutely. Especially for preventing those cardiovascular events we talked about, heart attacks and strokes.
Right. It's like the go-to prevention strategy for so many people. But I'm guessing it's not without its risks, right?
You're right about that. Every drug has potential downsides.
And with aspirin, it's
bleeding.
Makes sense if it's affecting how well your blood clots.
Exactly. Because it impacts platelet function so broadly, there's always a risk of bleeding, especially in the stomach or intestines.
Right, that risk versus benefit thing. Doctors always have to weigh that carefully.
Absolutely. It's a constant balancing act.
So aspirin's effective, but it's clear we need other options too.
Especially for people who might be at higher risk of bleeding.
Exactly. And that's where those P2Y12 receptor antagonists come in. Now, those sound a lot more complicated.
They might sound intimidating, but the concept's actually pretty straightforward.
Okay, I'm all ears. Simplify it for me.
Remember how we talked about platelets needing a signal to become sticky? Well, this class of drugs blocks a specific receptor on the platelet.
A receptor, like a little antenna that receives the signal.
Exactly. It's called the P2Y12 receptor. It's like a docking station for a specific chemical messenger.
Okay, so aspirin blocks the signal itself, but these drugs block the signal from being received.
You got it. It's like having a busy signal on the phone line the message can't get through.
Ah, that makes sense. So the platelets never get the message to activate and become sticky. And these P2Y12 inhibitors, are there different types?
Yep. Just like with aspirin, there are irreversible and reversible versions.
Reversible meaning the drug's effect wears off eventually.
Exactly. And that gives doctors more control. They can adjust the dosage more easily.
So like irreversible ones would be for more long-term prevention.
You got it.
That's really interesting. It's like having different tools for different jobs. Okay, so most of these are irreversible, but how do doctors, how do they adjust the dose if needed?
Well, that's where those reversible ones come in handy, right? They allow for more precise adjustments.
I see. So they're like a more delicate tool.
Exactly. But even with those irreversible ones, doctors take lots of things into account when deciding on a dose.
But what kinds of things?
Oh, the patient's weight, their age, other health conditions, all of that.
Wow. So much to consider. Okay, let's zoom in on one specific P2Y12 inhibitor for a second. Clopidogrel. My research mentioned it being a prodrug. What does that even mean?
Clopidogrel. It's a fascinating example of how our bodies can be, tricky.
Tricky how?
A prodrug. Think of it like an undercover agent.
Okay, I'm intrigued.
It needs to be activated before it can do its job.
So the Clopidogrel pill you swallow,
Yeah.
it's not actually doing the work directly.
Exactly. It needs to be transformed, metabolized in the body to become active.
And what part of the body does this activation?
The liver. It uses a specific enzyme called CYP2C19 to activate clopidogrel.
CYP2C19. Okay, I'm writing this down. So clopidogrel gets activated in the liver, and then it's ready to block those P2Y12 receptors.
You got it. But here's where things get even more interesting.
Oh, more interesting. Does this mean it gets even more complicated?
People actually have genetic variations in this CYP2C19 enzyme.
Hold on, so our genes can affect how well this drug works?
Exactly. Some people are what we call poor metabolizers.
Meaning?
Their livers don't activate clopidogrel as efficiently.
Wow, so someone could be taking the drug, but it might not be working as well as it should.
Exactly, and this is something doctors are becoming increasingly aware of.
So do they test everyone for this genetic variation?
Not routinely, but they might consider genetic testing if someone isn't responding to clopidogrel as expected.
That's really amazing. It's like personalized medicine, taking our individual genetics into account.
It really is. It's a whole new frontier in healthcare.
Okay, before we get too carried away with genetics, my research also mentioned drug interactions, specifically with clopidogrel and some common heartburn medications.
Oh, right, like omeprazole and esomeprazole?
Yes, those are the ones. What's the deal there?
Well, it turns out those heartburn meds can actually interfere with the activation of clopidogrel.
Oh no, so they're like blocking the undercover agent's training.
In a way, yes, and that means clopidogrel might not be as effective at preventing clots.
So it's really important for people taking clopidogrel to talk to their doctors about all the other medications they're taking.
Absolutely.
This is a great reminder for all of us to be proactive about our health. So we've covered aspirin, we've talked about clopidogrel and those fascinating prodrugs, and we've even touched on genetic variations.
And we've only just scratched the surface of the P2Y12 inhibitors.
There are even more.
Oh yeah, this family's got a lot of members, each with its own quirks and uses.
All right, well, I'm ready to meet the rest of the P2Y12 clan. Lead the way.
Let's do it.
All right, so we've explored aspirin, we dove into clopidogrel and those fascinating prodrugs, and we even touched on those genetic variations.
Yeah, those CYP enzymes always keeping us on our toes.
But there's more, right? More P2Y12 inhibitors.
Definitely. This family's got a pretty big roster, each with their own strengths and weaknesses, you could say.
Okay, I'm ready to hear about these other players. Who's next on the list?
Well, let's talk about prasugrel. It's kind of like clopidogrel's stronger, faster cousin.
Okay, stronger and faster. That sounds intense.
It is. It also binds irreversibly to those P2Y12 receptors.
So it's like shutting down those receptors for good.
Exactly. It's really effective at preventing platelets from getting that activation message.
So when would you use prasugrel instead of, say, clopidogrel?
Well, prasugrel is often preferred in situations where you need a really rapid and potent antiplatelet effect.
Like an emergency situation.
Exactly, like during a heart attack. Time is of the essence in those cases.
That makes a lot of sense. But if it's so strong, wouldn't there be a higher risk of bleeding?
That's a great question, and you're absolutely right. It's a trade-off, like with any medication. Prasugrel's potency does come with an increased risk of bleeding compared to clopidogrel.
So it's all about finding that balance, right? Weighing the risks and benefits.
Precisely. It's a delicate balancing act. Doctors have to consider each patient individually and choose the best option for their specific situation.
Speaking of balancing acts, what about those reversible P2Y12 inhibitors? I know we touched on those briefly.
Right. So unlike prasugrel, which binds irreversibly, these reversible inhibitors have a shorter duration of action.
So their effects wear off more quickly.
Exactly. And that gives doctors more control over how long the antiplatelet effects last. It's like having a dimmer switch instead of just an on-off switch, if you will.
Oh, that's a great analogy. I love that. So more fine-tuned control with these reversible inhibitors. When would you choose a reversible inhibitor over an irreversible one?
Well, there are several scenarios where a reversible inhibitor might be preferred. For instance, if a patient has a history of bleeding or is at higher risk for bleeding complications, a reversible inhibitor like ticagrelor might be a safer option.
Ticlopidine, that's one of those reversible P2Y12 inhibitors, right?
Yes, that's right. And because it's reversible, it allows for more precise control over platelet function, which can be crucial during certain procedures where bleeding is a major concern.
So it's all about tailoring the treatment to the individual patient.
Right, exactly. It's not one size fits all when it comes to antiplatelet therapy.
We talked about prasugrel and ticagrelor. Any other notable players in this family of reversible P2Y12 inhibitors?
Yes, there's also cangrelor, and it's unique in that it's given intravenously.
Intravenously, that's different from the others, right?
Yes, most of the others are taken orally in pill form, but cangrelor is given directly into the bloodstream.
So I'm guessing that means it works more quickly.
You got it. It has a very rapid onset of action, which makes it particularly useful in certain situations.
Like during a procedure.
Exactly. Procedures like angioplasty, where you need to quickly and effectively prevent clot formation.
Angioplasty. We keep coming back to that. Those stents and preventing clots around them.
Right. Cangrelor is often used during those procedures to provide immediate antiplatelet protection.
So it kicks in fast, and then because it's reversible, its effects wear off relatively quickly after the procedure's over.
Exactly. It's like a precision tool, providing rapid protection right when and where it's needed.
This is really fascinating stuff. Okay, before we move on to a completely different class of antiplatelet drugs, my research mentioned a drug called Ticlopidine, but also said it's no longer available in the U.S. What happened there?
Oh, yeah. Ticlopidine.
Yeah.
It was actually one of the first P2Y12 inhibitors, but it ran into some trouble down the road.
What kind of trouble?
It was linked to a higher risk of a serious condition called neutropenia.
Neutropenia, that sounds not good.
It's not. Basically, it's a condition where your body doesn't produce enough neutrophils.
Neutrophils. Those are, hold on, remind me.
A type of white blood cell, a very important type.
Right. White blood cells, they fight off infections. So, not enough neutrophils.
Means your immune system is weakened. You're much more susceptible to infections.
It's not just any infections, right?
Right. Serious infections, even life-threatening ones.
Wow, that's a big deal. So, Ticlopidine, while effective at preventing clots, had this potential for a really serious side effect.
Exactly. And ultimately, the risks outweighed the benefits, leading to its withdrawal from the U.S. market.
That's a good reminder that even medications that can be life-saving can sometimes have serious downsides. It's a constant process of evaluating and reevaluating.
Absolutely. Drug development is always evolving, and safety is paramount.
Okay, ready to explore another class of antiplatelet drugs. I'm eager to learn what other weapons are in this arsenal.
Let's do it. There's a whole other world of antiplatelet strategies to explore. Next up, a class of drugs that takes a very direct approach to preventing those clots.
All right, we've covered a lot of ground already. Aspirin, those P2Y12 inhibitors, even that cautionary tale about Ticlopidine.
Yeah, those early drugs, they definitely paved the way, but we've come a long way since then.
So what other antiplatelet strategies are out there? What else is in the doctor's toolbox?
Well, let's talk about the glycoprotein IBA inhibitors. They're a mouthful to say, but they basically do exactly what their name suggests.
Okay, I'm intrigued, but I need a little help with the name. Glycoprotein IBA inhibitors. What are those exactly?
They're receptors on the surface of platelets. Think of them as little hooks.
Hooks. What do they hook onto?
Fibrinogen. Remember that sticky protein we talked about? It acts like glue, holding those platelets together to form a clot.
Right, fibrinogen. It's all coming back to me now. So these glycoprotein IBA inhibitors block those hooks. Like they prevent the fibrinogen from attaching.
Exactly. It's like putting a cover over the glue bottle. No matter how activated those platelets are, they can't stick together without that fibrinogen connection.
Wow, that's pretty clever. A very direct approach. So when would doctors use these glycoprotein IBA inhibitors?
Because they're so powerful, they're usually reserved for situations where you absolutely need to prevent clot formation.
Like during a procedure.
Exactly. Procedures like angioplasty, where you're putting in a stent to open up a blocked artery.
Angioplasty. We keep coming back to that. It seems like that procedure has a high risk of clot formation.
It does. And these drugs provide that extra level of protection during the procedure.
Okay, that makes sense. My notes mention 3 specific drugs in this class: Ipsiximab, Tirofibon, and eptifibatide. Are they all pretty much the same, or are there differences between them?
They all target that same glycoprotein I-bivia receptor, but there are subtle differences in how they bind and how long their effects last.
So Ipsiximab, Tirofibon, eptifibatide, doctors have to choose the best one for each situation based on those subtle differences.
Exactly. It's like having different types of glue remover. Some are stronger, some work faster, some are better for delicate surfaces. It all depends on what you're trying to achieve.
I love that analogy. Okay, let's shift gears a bit and talk about Dipyridamole. This one seems to be a bit different, right? It's not just an antiplatelet drug, but also a vasodilator.
You're right. Dipyridamole is kind of a 2-for-1 deal.
Okay, explain that to me. How does it work on both fronts?
On one hand, it inhibits platelet aggregation, just like the other drugs we've discussed, but it also widens blood vessels, which improves blood flow.
Now that's interesting, but doesn't that seem a little counterintuitive? If you're trying to prevent bleeding, wouldn't widening blood vessels actually increase the risk?
That's a really good point, and it's definitely something doctors take into consideration. The vasodilating effect of dipyridamole is generally mild, and it's often used in combination with aspirin, which actually has opposing effects on blood vessels, so they kind of balance each other out. So it's like a carefully choreographed dance, using drugs with different but complementary mechanisms to achieve that optimal balance.
I see. And what's dipyridamole typically used for?
It's often used for stroke prevention, especially in people who've already had a TIA or a stroke.
Right, so it's like trying to prevent a second stroke from happening. Makes sense.
And because it can improve blood flow, it's also sometimes used in people who've had heart valve replacements.
To prevent clots from forming on those artificial valves.
Exactly. It's a pretty versatile drug.
Okay, last but not least, let's talk about cilostazol. My research mentioned it's similar to dipyridamole in some ways. Fill me in on the details.
Cilostazol also has those dual actions, antiplatelet and vasodilating.
So it reduces platelet stickiness and widens blood vessels.
You got it. But it works by targeting a different enzyme than dipyridamole.
Different pathway, similar outcome. Okay, I'm following. And what's cilostazol primarily used for?
It's specifically approved for treating symptoms of intermittent claudication.
Intermittent claudication. Okay, I need a quick refresher on that one. What is it again?
It's a condition where people have pain in their legs, especially when they walk, because of poor blood flow to the muscles. Cilostazol helps improve that blood flow, reducing the pain.
So it's like addressing the root cause of the problem, improving circulation, rather than just masking the symptoms.
That's great. Wow, we've covered an incredible amount of information in this deep dive. Aspirin, the P2Y12 inhibitors, those powerful glycoprotein IBA inhibitors, and even dipyridamole and cilostazol, with their dual actions. It's amazing how many different ways there are to target those pesky blood clots.
It really is. And it just goes to show how complex the human body is and how much research has gone into developing these targeted therapies.
But I have to say, it can also feel a little overwhelming. If there are so many options, how do doctors know which antiplatelet drug to choose for each individual patient? It seems like such a complicated decision.
You're right. It's definitely not a one-size-fits-all situation. Doctors consider a whole range of factors when making these decisions. Like what? Give me some examples.
Well, the patient's age, their overall health, their medical history, any other medications they're taking.
Right, because we talked about those drug interactions. Some medications can interfere with others.
Exactly. And of course, the specific condition the patient has, whether it's preventing a stroke or a heart attack or managing symptoms of PAD, it's about tailoring the treatment to each individual's needs and risks.
It's like a puzzle, putting all the pieces together to find the best solution.
Exactly. And it's an ongoing process. Doctors monitor how patients respond to the chosen medication, and they're always ready to adjust the treatment plan if needed.
That's reassuring. It's not just about prescribing a pill and sending the patient on their way.
Yeah.
It's about ongoing care and communication.
Absolutely. It's a partnership between the doctor and the patient.
Well, this has been a fascinating journey through the world of antiplatelet drugs. I've learned so much, and I hope our listeners have too. We've explored different drug classes, different mechanisms of action, different uses, different risks and benefits. It's a lot to take in, but it's so important to be informed and to ask questions.
I completely agree. The more you know, the better equipped you are to advocate for your own health.
And to our listeners, remember, this is just a starting point. We've given you a foundation, but the world of medicine is constantly evolving. There's always new research, new discoveries, new treatments on the horizon. So stay curious, stay informed, and keep those brains buzzing. And that wraps up another episode of The Deep Dive. Until next time, keep exploring, keep questioning, and keep diving deep into the fascinating world around us.